Abdominal aorta. Abdominal aorta is going to be here. Common iliac artery is going to be this. Foramina valley is between the right atrium and the left atrium. Internal iliac arteries is here. The umbilical cord itself is this one. Aortic arch, the same as the ductus arteriosus is between the pulmonary artery and the aorta. So it's got to be here. Hepatic portal vein is this guy here. Superior vena cava is here. The umbilical vein is red, so this is it. Ascending aorta, right, where's the, wait, I think I wrote the arch here. Let's call this the ascending aorta. And then this would have to be the aortic arch. Ductus venosus is happening here. And the inferior vena cava is here. And that will leave the umbilical arteries, which would be these two here. Okay, and that's fetal circulation. I mean, most of the anatomy is similar to normal outside when you have normal circulation, and then of course the added shunts as well. All right, so now here's the very tricky part for some babies. They have a hard time transitioning from intrauterine to extrauterine. So usually everything is fine. So you get the baby to take that first deep breath. And with that first deep breath, that's going to help to decrease the pulmonary vascular resistance, because now fresh oxygen is going into the lungs, and also that first breath is helping to expand those alveoli, and because they've been filled with fluid for all that time, and so that's the whole point. Now the cord clamping thing, it's just like anything else in medicine. Things change. So it used to be that they would clamp the cord right away and then cut the cord. But now there's a lot of people saying, especially like a lot of midwives, they're saying, really, hold off on clamping the cord, because there's so much blood that's still in that placenta that if you clamp it too soon, then the baby may end up being hypovolemic. And so now they're looking at just waiting at least like a minute or two. And in some cases, like especially if you go to a midwife, they're going to probably have you connected, still have the baby still connected for like minutes before they actually do anything with it. So again, it's just kind of like, it just depends on what your school of thought is. But when you do clamp the cord, that's when everything does switch, as far as the right side of the system will now become the low pressure side, because the vascular resistance is now decreased. And then the left side of the system would come your high pressure side, as we know it to be. Blood pressure is greater on the left side compared to the right side. And then these shunts here, the foramen valley, because it's just a flap, essentially the pressure itself is going to make sure that it closes. And then over time it gets what's the word I'm for? Fibrous, and it just becomes the foramen fossa, which is just like a little indentation between the right atrium and the left atrium. The ductus arteriosus. So here we're saying that there's multiple things going on as far as why this will close. Technically, this artery, this ductus arteriosus, I should say, it actually starts closing right before the baby's born. So it's like at the end of the third trimester, things are already starting to change physiologically, and that ductus arteriosus is preparing to close. But as soon as the baby takes the first breath, for sure, that's going to help to ensure that it starts to close. And then the placenta had been producing a lot of prostaglandins, and prostaglandins are designed to keep it open. So they act as like, you can think almost like vasodilators. And I'm sorry, they're meant to, just think of them as a vasodilator. So now, without those prostaglandins circulating, then that's going to help to ensure that the ductus closes as well. So we've got some figures here, 20%, 80%, and 100%. And this is kind of consistent with what a lot of the other people out there are saying, as far as you'd expect like around a couple of days, the baby should have practically the entire ductus completely closed. And then 4 days later, then it should be completely closed. Now, when we get into the heart defects, the cardiac anomalies and that sort of thing, we'll see that sometimes these things will just reopen on their own. And then other times they'll have to reopen because there's another problem with the heart. And it's like, this is the only way that the baby will survive if this ductus reopens. Sometimes they have to go in and surgically do something. They have to sometimes surgically close it or cut it, or they have to like ligate it, or they give medications to do one or the other, to reopen it or to try to keep it closed. Okay, so now questions. What appears to be alveoli can be found during which phase? So the word here is appears to be. So don't believe your eyes. All right, so it's the pseudoglandular phase. They're not really alveoli. They kind of look like alveoli. They're just like glands, and that's the appearance that they take on. Then we got two fill in the blanks here. If you hadn't already started working on the homework, you haven't already researched this, or if you just aren't already familiar with these terminologies. So when it comes to the fetus's protection while in utero, you got to have something on your skin to keep that amniotic fluid from just always keeping you like a little raisin. I guess you could look at it that way. So there's this coating that they have for that reason, and it also to help to prevent like any kind of like to make it easier to pass through the birth canal. There's like this cheesy like substance that's all over their skin. It looks like cheesy white in color. And then they also have like a little layer of very fine hair that's acting as like an insulator and also for protection. And at some point, that little layer of hair, which is known as lanugo, it'll start to fall off as the fetus gets older. And it starts off as like white, and then as they get older, it again falls off and it gets darker. So if you've got a fetus who hasn't really had a chance to develop fully, you'd expect them not to have gone through that stage yet where all of that lanugo has started to darken and fall off. So the answer we're looking for here is the younger the preemie, the more lanugo that you're going to see when you're doing your evaluation or doing your assessment. And then if it weren't for which one of these? So which one of these is responsible for keeping the lungs inflated so they can continue to develop in utero? Fetal lung fluid, yes. So that's the main point of secreting that fluid. So that way their alveoli don't collapse and their lungs can grow like they're supposed to. And although too early, a fetus may still have so a fetus is still viable. So the word that they always use to mean able to survive or live. Survival, viable or viability. The canalicular, yes. That's when they start their surfactant production. Now, granted, it's not mature surfactant, so the LS ratio isn't more than 2 to 1 yet, but still they have a much better chance compared to say if they were they were born during the pseudoglandular stage. True or false? Okay, so we have false. Right. It's not. It's the increase in pressure on the left side that's going to that's basically going to cause this flap to close. So it's not increase in venous return, which would be like blood returning to the right side of the heart. It's just that you've got lower pressure now on the left side because of the drop in vascular resistance, pulmonary vascular resistance, and then you're separated from the placenta. So yeah, everything will. That's all that's going to help to ensure that the pressures increase on the left side of the system and force the flap to close. And which germ layer are we referring to here? So both words would have to make sense. Okay? Yeah, that's the only thing that makes sense here because we say that the innermost germ layer, which is the endoderm, is going to give way to the lungs and your respiratory system, your airways, and that sort of thing. As well as your digestive system. And now, how many? All right, so you have two arteries in a vein is what it should be. Now, will there be some abnormalities? Sometimes maybe, but in most cases, there's not going to be any abnormalities, and you'll see what you should expect to see when you're looking at the cord. All right, now let's move on to chapters 3 and 4.